Hello there everyone, my name is Kamran Bhopal and yet we're here with another emergency scenario on acute urinary retention. So you've got a question saying, this is for the ST3 national training interviews, national training numbers. So we've got a question saying 62-year-old gentleman with 6-month history of lower urinary tract symptoms attends accident emergency, unable to pass urine for 8 hours and is distressed. How would you assess this patient? So you would assess this patient according to the CRISP protocol, A to E, and resuscitate if necessary. If possible, I will take a focus history after giving some analgesia. History will include lower urinary tract symptoms, including storage and voidic symptoms, and the onset, duration, and progression of these symptoms. I'll ask for any UTI symptoms, any previous history of retention, and whether he was catheterized recently or any other recent instrumentation or urological procedures. Ask for history of prostate cancer, bladder cancer, benign prostatic hyperplasia, strictures, etc. Ask for medications such as tamsulosin, finasteride, anticoagulation, and any allergies. Also ask for any anticholinergics or beta-3 agonists. And I will check for bowel function as well. Then I would examine the patient in the presence of a chaperone, checking for cachexia, discomfort, so a general examination, and then specific abdominal examination looking for flank pain, palpable bladder, abdominal scars, and a genital exam looking for any tight phimosis, meatal stenosis, etc. And a DRE, which can wait till after the catheterization, which will be done to look at the size, the tenderness, and any signs of malignancy such as cragginess and firmness or irregularity of the prostate. If there's any doubt of urinary retention, we should do a bladder scan. What is your differential diagnosis? So there's multiple differential diagnoses here. So you should be able to categorize them because then you've touched every little bit. So mine were, okay, you've got structural causes such as benign prostatic hyperplasia, urethral strictures, prostate cancer, tight phimosis, meatal stenosis. Then you've got post-operative causes such as post-operative retention or clot retention. Then you've got infective causes such as prostatitis and urinary tract infection, medication-related anticholinergics or beta-3 agonists, and then we've got neurological causes such as multiple sclerosis, lumbosacral nerve root compression, S2 to S5 traumatic injury, Fowler syndrome, and then extrinsic compression such as constipation, pelvic masses, cystocele, urethral diverticulum. So there's so many causes of acute retention. I mean, you can score very well in this scenario, but at the same time, you might not because they want to hear a little bit from each category. So, put some structural causes, some infective causes, some medication causes, some post-operative causes, some neurological causes, and extrinsic compression causes. What are the investigations you would do? So, full blood count, use any CRP, clotting, PSA, very important, and I would also request an ultrasound KUB, and that is keeping in mind, high pressure chronic retention. Is PSA helpful? So this is a straightforward answer because obviously with catheterization and retention, PSA will be raised. So you can say PSA can be raised in context of acute retention, but significantly high values such as in the hundreds indicate advanced prostate cancer. Hence, I would do a PSA if my DRE was suspicious. But you can say it in multiple ways, and that's what I do. So if this is what I practically do. So if I catheterize someone, I do a digital rectal examination. And if it's smooth, I don't bother doing a PSA. But if it does feel like it's malignant, yeah, I would do a PSA. Even in the context of retention and urinary catheterization just now, I would still do a PSA. Because if it's T3, T4 disease or T3 disease on DRE, that means, it can be T3/T4 disease and you need a PSA to see if it's metastatic. So how would you proceed? The bladder scan shows 999 mils. So there's, they just want to know what will you do stepwise. So 14 French two-way catheter with 2 Instella gels with patient lying flat. Then 14 or 16 French two-way CUDA tip catheter. Then if that fails, then I can consider a catheter introducer if someone had the skills, or call the on-call consultant if he had the skill to do that, and I would be able to utilize this skill. I would then use if that fails, flexible cystoscope guide wire insertion. If that fails, I will call my consultant in view of insertion of an SPC, which should ideally be done under ultrasound guidance, ensuring there's no intervening bowel. And then if you've done that, then you would note, the residual volume of the urine, send a urine culture, document in the notes, and do a DRE if not already done. So then there will be a question of post-obstructive diuresis. So a patient has drained 2 liter post-void residual, 400 mils per hour for the last 3 hours. How will you manage the situation? So you say, I'm concerned about post-obstructive diuresis if there's anything greater than 200 mils per hour, and then I would monitor the urine input and output very closely and replace half of the fluids from the last hour, of the last hour's output. So replace half of the fluids, half in fluids, as compared to the output of the urine output of the last hour. So, and USINE should be repeated 12 hours post-catheter session to correct electrolytes, and blood pressure and heart rate should be closely monitored. Then there's a simple question about catheter balloon. What do you use in it, saline or sterile water? And it's only sterile water, because saline crystallizes within the balloon, and that might become a problem later on. So what if, actually this was a question that came across. This is not a question within but it didn't come in the interview, but one of my colleagues just said, okay, fine, someone's put normal saline in and the balloon is filled. What would you do moving on? Sorry, it can be deflated, and what would you do moving on? So, it's just literal practice, clinical practice, and you can say things like, I would try to aspirate the balloon. If it doesn't work, I will try to inflate the balloon and then try to aspirate. If that doesn't work, I'll cut off the balloon port, and if that doesn't work, then I would use a stiff guide wire via the catheter balloon port to puncture the balloon. You can essentially do, it's very difficult to do a flexible cystoscopy besides the catheter, but the next step is, doing some sort of a cystoscopy to then puncture the balloon that way. But, hopefully we won't come to that stage. And the answer should usually finish. You'll use a guide wire through the catheter balloon port to puncture the balloon. So that's about it for this station, and I'll see you in the next station or scenario, which is on infected obstructed system. All the best.